have the QED indicators are also meant to show if at all we're making any progress. Next slide, please. So the scope of this program is that we target all women admitted for childbirth or within 42 days of childbirth or spontaneous loss or termination of pregnancy, irrespective of the site or duration of pregnancy, and their newborn babies. And we're targeting that because we want to cover all the various causes of maternal mortality and ensure that we capture them on our database. So we're including data from patients that have ectopic pregnancy, those that have hydatidiformal, those that have miscarriages, things that are not normally routinely covered. And we ensure that we also take data from all newborn babies up to the first week of life. We also conduct what we call facility audits because some of the QED indicators include the need to visit health facilities and key events related to the woman, including key intrapartum, antepartum, intrapartum, and postpartum events. And like I said, if the mother dies, death audits are also done and also recorded into our database. And for the baby, we record data up to, routine data up to the early neonatal record, up to the first week of life, to ensure that we cover the neonatal period. And if death occurs, also death audits are done and also imputed into the national database. So we are able to cover a number of quality of care indicators in the process. These are the listed quality of care indicators that are covered by our database. The last two are the data indicators that are actually captured as we do a facility audit. The rest are covered through our database capture routinely done by the medical record officers. Next slide, please. So how was this program developed? First of all, the Federal Ministry of Health in Nigeria and the Program Central Coordinating Team met to discuss how to develop the program in line with existing Federal Ministry of Health processes. And one of the information we had at the beginning of this program 3 years ago was that actually collection of data from tertiary health facilities has been a challenge. We developed data capture tools, and these data capture tools were reviewed by the WHO, Nigerian National Health Research Ethics Committee, and also institutional ethics committees. So we got approval from all these bodies on our data capture tool and the whole program. And then we developed the DHIS2 electronic platform. We developed our tools along the line of the DHIS2 electronic platform for the aim of sustainability, because the national platform, the national record system is actually based on DHIS2. So we developed that through a number of consultative processes. We developed SOPs and manuals, and then we went around all the 6 regions of Nigeria to train all the program personnel and to ensure that they were comfortable about the use of the system and the data capture. And we also put support systems in place, because we know that even if after training, people were going to have some challenges. And we had the support system where people could call if they had challenges in inputting data and so on and so forth. So this was part of the program development. So the network actually involves 54 Nigeria referral level public and private hospitals. We make sure all the big tertiary health facilities report to our system. And this is based on the success we had earlier recorded, because we actually had a network which had done some work even before then. So we just used the same platform to invite this new network. And then the platform was officially launched by the Minister of Health on the 24th April 2019, more than 3 years ago. And data collection commenced at all the participating health hospitals on 1st September 2019. And as we can see from the picture, the Director of Family Health then, who is now the Director of Hospital Services, Dr. Adebimpe Adebi, represented the Honorable Minister of Health in officially launching the platform And then the Honorable Minister of Health at that time, who was also available and also graced the occasion of the commencement of this program, Professor Isaac Adewale. That was 3 years ago. And as we can see also in the picture, we also had Dr. Femi Olufemi Oladapo of the WHO, who is a Nigerian and actually one of the main forces behind this program, also available at the official launching of the program. Next slide, please. This is the structure of the program. As we can see, we have medical record officers and at all our participating 54 tertiary health facilities. So in each health facility, we have 2 medical record officers to ensure that they capture routine data from both obstetrics and the special care baby unit, the first 1 week of life. So they work together with hospital coordinators. And in each hospital coordinator, we also have 2 hospital coordinators, 1 obstetrician and 1 neonatologist. And they also report to what you call regional coordinators. Now, Nigeria has 6 regions. And in each of these regions, we have very senior colleagues who oversee all these regions and participate as regional coordinators. And then the regional coordinators report to the central coordinating team, which I chair. And in the central coordinating team, we also have eHealth. The eHealth is a Nigerian company that is at the backbone of the monitoring the database, the electronic database. We work together to develop it. And if there are any challenges, they address the platform. So this is the overall structure of the program. Now, this is how the program looks like. And as you can see, we have given the chance to medical record officers, to hospital coordinators, and all the participating personnel to be able to log in. We have login details of each of them. They click, they register, and they're able to admit and record data from the patients, depending on the kind of patient, include obstetrics, gynecology, and outbound baby admission. And after having done that, they save, complete, sync it to cloud, and then we're able to visualize this data on the dashboard, which I will soon show example. And as I said earlier, we also have facility audits. And these facility audits are conducted usually by the regional coordinators. We do that twice a year. And these facility audits look at a number of things, including the personnel, condition of the facility, availability of consumables, basic hygiene, and so on and so forth. They are also able to upload this data, and this is also synced to the cloud, to the central database, and we're able to analyze and download this data and able to give feedback to the various facilities, the various regions, and also to the country from time to time. So we also developed 2 operating manuals that help to guide our people, including the ICD codes for the causes of maternal and perinatal deaths, to guide information whenever people want to input data related to deaths of either perinatal or maternal deaths, as is done by hospital coordinators. Next slide, please. So having said that, we also have a number of quality assurance processes. Our database has validation rules, a number of validation rules that prevents our medical record officers and hospital coordinators from inputting wrong things. So the platform has a number of things I will not accept, just to make sure that people, their attention is called if they are going to input something that is wrong. We also have weekly enrollment reports. We review this report every week, and we review it together. And if there are issues that we need to call the attention of other medical record officers, hospital coordinators, we do that. We do monthly data quality checks. We send emails, we make calls to all our various personnel if there is any issue related to the data. We also have a monthly regional call where we go through all this data with all our personnel monitor and find out if there are any issues that need to be sorted out. And these are sorted out at these monthly regional calls, which we do by Zoom. And this is all aimed at ensuring that the quality of what we're inputting is very good. This is an example of how the tablet looks like that is used by the medical record officers. There are simple ways of inputting. We don't have much typing. It's mainly Dropbox. And there are compulsory items. And like I said, we have a number of validation rules that help to make sure that mistakes are not made, especially by the medical record officers. So this is how the tablet looks like, which is used by the medical record officers. And this is how the platform looks like, the dashboard. Like we said, we've done a lot of work over the last 3 years to improve this dashboard. And as we can see, for example, this dashboard is showing maternal mortality ratio of Nigeria. Now we know that we're not capturing data for the country. We're capturing data for only tertiary health facilities. We still have secondary health facilities. We have primary health centers. We have community data. So, but we're referring to Nigeria of our program. So, and as we can see, this shows, for example, this dashboard is looking at maternal mortality rate. We have a number of things on our dashboard that simplifies the data that we're capturing into simple, readable, and usable items. Next slide, please. And again, this is an example of the dashboard showing, for example, this is looking at perinatal mortality rates. And again, this is just to simplify this data that is available for our use, either at the facility, regional, or national levels. Next slide, please. So how do we collect this data? So for the medical record officers, they use tablets, which of course has limited functionality and is mainly for data capturing, doesn't do much of data viewing or analysis, used by medical record officers. And it's internet enabled. So we use internet, we make sure there's data, and whatever data they capture, as they capture routine data, this is now synchronized online and with the national platform, online and offline. The hospital coordinators are able to view their data using their own personal computers. It has full DHIS2 functionality, as I mentioned earlier. They're able to view their dashboard. They're able to download data and do some interim analysis. Apart from we're also able to access the same data by the regional coordinators and also the national team. And like I said, we always try to give feedback on the data to facilities, to regions, and the nationally, especially to the Federal Ministry of Health from time to time. Next slide, please. So how is this data actually collected? Like we said, we have medical record officers. They make daily visits. And because we capture routine data, we try to capture data of the last 24 hours. So the medical record officers obtain this data from medical records. So they collect the patient folders and download, look at the records, and from there they're able to capture the data on their tablets. So they complete and upload the electronic data capture form, which we earlier talked about from the beginning for all women and their baby. So the form is completed immediately after discharge or death of the mother and or baby. And the collected data covers the period that the mother and the woman and baby were on hospital admission. And data extraction is restricted to what is available in the medical records of women and baby. So we do not interview women for their data or their baby. We collect the data from what is available in the medical records. Now, in the event of the death of the mother or baby, additional information is filled in the relevant forms after a death audit has already been done in the health facility. So this includes clinical condition responsible for the death and contributory factors. So this is obtained from the hospital maternal and perinatal death audits, and this is done by the hospital coordinators. They do the death audits. And like I mentioned, we do 3 types of audits. One is maternal death audits, then the stillbirth audits. Now, these two are done by the obstetricians, while the neonatologist does the early neonatal mortality death audits if they occur. Now, this data is used in a number of ways. Like we mentioned, when we have death audits, we link these death audits to other information that is already captured about the patient, because we capture this information for all patients that deliver in the hospitals. So when there is a maternal and perinatal death audit, we link the deaths to other information, including the social, demographic, and clinical data. We're able to analyze these deaths, and we're able to generate and download the QED indicators in the forms of graphs, tables, and these are available at the dashboard and is reviewed at hospital, regional, and national levels. And we're able to see changes that happen over time. This data can be analyzed at facility, regional, and national levels, and we do periodic reporting on QED indicators, on quality of care, and coverage of essential interventions, and we give feedback to facilities, regions, and the Federal Ministry of Health, and we're able to draw comparison between facilities and regions. And we're able to also export this raw data for statistical analysis. This program, because we capture routine data, is actually very rich in data. And we're able to be able to give so much information apart from the QED indicators. We're able to look at things like referrals, their influence, as basic as when women come in labor, what cervical dilatation, whether the membranes were ruptured, and so on and so forth. This is all available because the data is routine, but we also have our emphasis on the QED data, and that is quite available. Next slide, please. So we have a number of achievements to date. Like we mentioned, in each of our 54 health facilities, we have 4 workers, our 2 hospital coordinators, and our medical record officers. So we have over 200 people that have been mobilized, trained, and highly motivated to do this work. We have a well-functioning dynamic platform, dynamic in the sense that it can be improved. It can be expanded to include antepartum events and postnatal events, and so on and so forth. And we've been doing ongoing analysis. We've been giving interim reporting. And the first year of data, we've looked at it in detail. We've looked at the quality of care data, and we're able to look at the outcomes for maternal and perinatal care, especially for the first year of data. And like I said, we started 1st October 2019. So we've actually done 3 years of continuous data collection. And we have more than 200,000 women on the data of more than 200,000 women and their babies. And I must say that, to my knowledge, this is the largest database for women and babies for Nigeria, and probably one of the biggest in Africa. So this is a major achievement. And the fact that after the first year, over 97% of deaths were audited of both maternal and perinatal death audits were conducted. So let's look at the first year of data. We've actually, this has actually been published in eClinical Medicine of this year in a presentation, Quality and Outcomes of Maternal and Perinatal Care for 76,563 pregnancies reported in a nationwide network of Nigerian referral level hospitals. Like, so this first year of data included 76,563 women. There were 69,000 live births, 4,498 stillbirths, and over 1,000 early neonatal deaths recorded in that data. The data was of high quality with less than 1% missing data on vital status. And there were a few gaps. The gaps were apparent in coverage of essential interventions and quality of care. So one of the things we noted in that data is that about 41% of the women had no complication during pregnancy, childbirth, or 42 days of postpartum, while almost 50% of women had a condition that was not potentially life-threatening. But then about 8.6% of women had life-threatening condition, including 1.2% women that died in the among the women that we collected in the data. So this was the burden of morbidity. And as you can see, these were the quality of care indicators that were recorded in the first year of data, with a pre-discharge maternal mortality ratio of 682 per 100,000 live births. But this ranged between the various regions from 430 to 97 per 100,000 live births. And we can see other quality of care indicators, including institutional stillbirth rates, national about 59 per 1,000 hospital births, antenatal stillbirth rates 26 per 1,000 stillbirths. One of the things we may also look at is the companionship in labor, which was quite low because for us in Nigeria, this is something rather new. We've not been paying much attention to it. And this clearly showed us one of the areas where we had low coverage with an average of 26% for the nation. The last two also were part of the quality of care indicators that we noted during the visits to health facilities. As you can see, the basic hygiene provision was rather high, being at tertiary health facilities 91%, and basic sanitation almost 90%. But then there are differences between the various regions in the country, from some having very low to some having very high coverages. Further analysis of the maternal mortality showed 944 deaths, but 910 were audited. And the highest contribution of maternal mortality was from hypertensive disorders, responsible for about 31% of maternal deaths, followed by obstetric hemorrhage, responsible for about 19% of maternal deaths, and then infection, responsible for about 16%. Even for patients that develop these conditions, the highest case fatality rates were for sepsis, with deaths occurring about 40% of those patients, and then eclampsia with almost 1/4 of patients that developed eclampsia dying from their condition. So these were some of the details that were available to us when we further analyzed maternal mortality in the first year of our data collection. So the one of the commentaries, as we can see, looked at this data, and as we can see, one of the comments as we can be quoted is that prospective surveillance of maternal and perinatal data, including the use of selected quality of care indicators, is critical for achieving the aims of WHO quality of care QED initiative and for meeting the third sustainable development goals target at country level. Importantly, a nationwide database program for harmonizing and aggregating data could be implemented in settings, because we have done it with similar medical record infrastructure as Nigeria, to identify interventions that could be implemented to drive policy change and impact. With global shift towards increased facility births and digitization of routine national and management systems, there is a huge potential to scale up this program to other countries. Before we started, what we had were aggregated researchers working in various health facilities, taking the same data, but we do not have access to this data of the various health facilities. But with this platform, we're able to aggregate this data into a single national platform. We're able to analyze it, and we're able to be able to differentiate this data into national, regional, and facility levels. We are currently exploring the leading causes of death in more details, and currently we've just finished secondary analysis on a number of issues: cesarean section, postpartum hemorrhage, hypertensive disorders, obstructive labor, early pregnancy loss, birth asphyxia, neonatal jaundice, preterm birth, and sepsis. And this is currently being planned for publication in BMC Pregnancy and Childbirth. And we have just done some corrections. And in this publication, BMC Pregnancy and Childbirth. So ladies and gentlemen, I will stop here and hand over to my colleague, Dr. Camille Shoretire, to continue. Thank you.
Thank you, Professor Jamilu, for that presentation. I would like to do screen sharing. You have a number of questions in the chat box. I think you should go through that so that you'll be able to respond to them as needed after my presentation. Once again, I thank everyone, our WHO team there, our team in Nigeria, our friends from different parts of the world. My task at this moment is to talk about the transition plan for the federal government of Nigeria with respect to this program. Just like we've listened to Professor Tuko, we've had 3 years of successful implementation of the MPD-4-QED project in Nigeria. And as was planned at the beginning, it was expected that by the end of this, we are able to institutionalize the objectives of this particular project, very interesting project, to helping us towards attainment of SDG goal number 3, which is to reduce maternal, perinatal, and child mortality across board. Okay. The Federal Ministry of Health has a supervisory role over most of the tertiary health institutions involved in this project. And like the previous speaker has mentioned, more than 60% of these tertiary health institutions under the Federal Ministry of Health are involved in this MPD-4-QED, while some more are getting on board, even as the project entered its last few months. Next, please. Since the discussion with the implementation team on the transition plans, we've taken some decisions at the Federal Ministry of Health level in Nigeria. Let me quickly say that health is on the concurrent list in the Constitution of the Federal Republic of Nigeria. And this translates to the fact that states, Nigeria is made up of federal government, state governments, and local governments. It means at the state level, issues of health can be handled independently of the federal government. And as we'll see in trying to expand this, the coverage of this MPD-4-QED program in the years to come, it will involve us to do advocacy, persuasive advocacy, to getting all the states of the Federal Republic of Nigeria. There are 36 of them, including the Federal Capital Territory, making the 37th subnational to buy fully into the program. So we collect some data collection regularly from these tertiary hospitals. And we are very glad that the quality of data with respect to what MPD-4-QED has provided has actually generated interest at the highest level in the ministry. The Federal Minister of Health is very much interested in this. And as a result, he has directed that this transition plan be done seamlessly to ensure that this data collection, collation, and analysis continues. And we ensure that at the national level, the database is so well established that transmission of data can continue from where this WHO MSD sponsored project terminates. We've also decided that in the meantime, we'll be retaining the services of the coordinating center headed by Professor Jamilu, and the current structure of data transmission, pending the time we are able to evaluate and see how well we can integrate this into the maternal, perinatal, child death surveillance and response system the MPDSR, which is about to be signed into law in Nigeria. This will capture more data, including that of the under 5 and other data that are needed beyond that of MPD-4-QED. We've also directed that the MPDSR, which will be the committee we establish at different tertiary health institutions under the federal supervision of the Federal Ministry of Health, that the chief executive of those facilities will be the chair persons of this committee that will handle all the data collection under the MPD-4-QED and other associated health data needed to do this surveillance and response system. We've also directed at the management of all these hospitals, federal tertiary health institutions, and other institutions at the state level. We've written some letters, and we are still doing the advocacy to ensure that they make the top management of their respective health facilities to be involved in this facility committee. This will ensure that logistics for data collection, analysis, and transmission is better handled and well supervised. Also improving stewardship and accountability with respect to what the objective of MPD-4-QED is all about. Next, please. Next, okay, thank you. Also, as part of this, a desk officer in the name of Dr. Vivian Okafor, who is working closely with me, he has been appointed in the interim to ensure that the supervisory role expected of the Ministry of Health is assured. And we've decided recently that we'll have a technical team in the ministry, which will also involve the team that have been working on MPD-4-QED for the past 3 years in the Department of Family Health in the Federal Ministry, to form a technical team that will ensure seamless management of this data platform, to be able to do the comprehensive analysis and ensure that decisions for action are taken. We've associated greatly with the selected quality of care indicators, and we intend to continue to track them and use them for assessment, evaluation of performances of our various maternal and child units in the various tertiary health institutions. We are also going to be doing selling this to the 36 states and the Federal Capital Territory of the country to ensure that the states buy into this and they also tag along this the use of this quality of care indicators. Ongoing discussion has started with the Galaxy Backbone Nigeria that this database will be hosted, and whatever is required, the Federal Ministry of Health is in the discussion. Once that is finalized, we'll let everybody be aware. We've also mooted the idea of having MNCH conference annually, which will also be the sharing experience on this data. We will be able to track, discuss these indicators, taking decisions, and of course, rewarding performing health institutions who are able to collect this data regularly, are able to do debt audits and take necessary action, especially in terms of services they are rendering, infrastructure, and budgetary provision to respond to some of the challenges or findings from this analysis. Next, please. Thank you. Since the past 6 months that I personally have been involved in tracking data collection, we've seen some of the facilities have challenges, mainly due to logistics that are being funded by WHO before now. And As a result of that, we've also directed from the ministry that our own hospitals, the federal tertiary health institutions, take ownership of this data collection and should be able to incentivize our medical records officers and the coordinators to be able to do this seamlessly without much hassles. And all these involved hospitals have been contacted on this, and some of the coordinators have even attested to this. Where there are still some challenges, I will give updates on what we have been able to do in the weeks to come. Yes, thank you. The Federal Ministry of Health, Department of Health Planning, Research and Statistics that is operating the DHIS2 is very much concerned that this data needs to flow seamlessly into the DHIS2. And this decision has been taken, and full integration of this is expected to take place in the next few weeks to ensure that as they come from the facility, they go on this platform and then also go into the DHIS, which is the bigger platform for all health data that we collect within Nigeria. The coordinating mechanism that just left the screen now is what has been designed to ensure that we comprehensively capture all data, both from the community, from the local government area, to states, health ministry of health, and then to federal. We intend to strengthen this. We intend to implement this and ensure that we have annual regular review of what challenges are being experienced at local government and state level, and with support of partners, of course, to ensure that we resolve these challenges and ensure that the smooth data collection and action decision-making after data analysis are done in a timely manner. And then during the annual results conference, I would say, we'll be able to discuss fully state by state, and also peculiar facilities that are performing so well will be exhibited, and be able to discuss that. Let me, at this point, on behalf of the Federal Ministry of Health, appreciate handsomely what WHO has been able to do, and MSD for mothers, with respect to this MPD. It's an eye-opening project. It has really brought so many things to the fore, and we are acting on some of these results that we have seen from it. The technical team in Geneva, Tina and co, we want to appreciate you for all you've done. And also, while we are planning this transition, the issue of MPDSR training manual came on board, and we saw UNICEF and JAPIGO coming in readily to support the training review of this manual. And I know we have done some parts. We still have more to do. We'll be counting on your support to ensure that we have a seamless integration of MPD-4-QED into the MPDSR, which is now to be backed by legislation, meaning that it's going to be funded, it's going to be sustained, and it will be compulsory for everyone to tag along. E-health for everyone and the team, for the technical training and support they've been giving my team, because we've set up a team at the Federal Ministry of Health that is understudying all the processes and appropriate support when we take over. And of course, Professor Jamilu Tuku and his team in Aminu Kano Teaching Hospital, and our various coordinators across the country in all the partner facilities. We thank them for the excellent job they've done so far, and we assure them that they have our full support in moving this program forward. Thank you very much. Listening. So I guess I have some questions too. Okay. All right, over to you, Tala or Joseph. Thank you.
Thank you very much, Professor Jamilu and Kamal, for the presentations. And thank you for all the questions that have come in. I believe we'll go straight into answering some of them and continue posting them in the chat box. We are monitoring, and we'll try as much as possible to answer all the questions. Maybe if I can start with you, Professor Jamilu, in terms of the processes. How do you capture the routine data in referral? Do you capture the routine data in referral facilities only, or also include the referring facilities? If referral only, will this program be expanded to other facilities?
Yeah, so for now, we started with tertiary level health facilities. When I talked about referral, you know, because tertiary health facilities are the last point of referral in Nigeria. The primary health facilities refer to secondary, secondary refer to tertiary. So that's what I mean by referral. We're capturing data for now for tertiary, but I believe the Federal Ministry of Health, as part of its expansion program, will expand it to the secondary and primary health centers. But for now, the program is located at tertiary health facilities.
Yeah, thank you, Professor Jamilu. And maybe you can also tell us, having described the process, there is a question on what advice you would give other countries yet to integrate MPDSR into DHIS2. And probably after you finish this, Camille, also you can come up with whatever advice you might have as you go into transition. Thank you.
Right. So when we started, we wanted something sustainable. We didn't look at it just from the point of view of a program that will come and go. We wanted something that even at the end of donor support, the government can continue. So we realized that the database for the nation is based on DHIS2. So I think it's important for any African country starting their own program to ensure that sustainability is discussed even at the beginning. So whatever system that is used nationally should also be used for any program that we want sustained. That was our target, and I hope other African countries will do the same. Thank you.
Camille, as you transition, any advice you would want to give to other countries yet to integrate MPDSR into DHIS2?
Okay. Well, thank you. I like other countries, I know some are not using federal system. Some are using a unitary style of government, in which case the federal government takes decisions for virtually all the big hospitals in the country. But for us, those that are operating a federal structure, it's very important, even at the beginning of this program, to, apart from discussing sustainability, to let the subnational be carried along, to know that something is happening and is going to be involving them anytime soon, so that some of them, not all of them, will move at the same rate. We have plans to be able to tag along this. For the transition, it's very important to share results, demonstrate the advantages of what has been done, the merits, and discuss the challenges, so that those that want to take over will be in the full knowledge of what has been done, what is to be achieved. Once we are able to do that, I think stakeholders will be able to go along to support. Even more partners will be able to commit funding to projecting this, since it is in the national strategic plan to reduce morbidity and mortality for mothers, newborns, and the young children. I saw a few questions that maybe we could respond to. I think Jamilu has mentioned one. Death outside facility. Currently, the National Primary Healthcare Development Agency, you would have seen the acronym in the presentation, NPACDA in Nigeria, is an agency that gives technical support to subnational in handling primary healthcare issues. They have a program that is developing verbal autopsy to be able to capture and know the deaths, the cause of death of several deaths that happen at the community level that do not get to the health facility. We at the Federal Ministry of Health will be working with them to ensure that this data flowing is happening in every community currently, because we still need the buy-in of the state. They'll be doing. On the plans to continue to capture other facilities at local government and private health facilities. On how
Camille, your network is breaking. Perhaps I'll come back to you. Your network is breaking. We cannot clearly hear you.
Can come in and support data collection and also, okay. Can you hear me now? All right.
Yes, your network is breaking. Perhaps I'll come back to you. Let me go back to Jamilu. Right. Jamilu, you really explained to yes, thank you. Okay. Thank you. Jamilu, you explained to us
that it's clearer now. Is it clear now?
Let's give it time. Let me ask Jamilu to just explain to us the data that you elaborated, the processes that you really took us through. How have facilities used that data to identify and address modifiable factors and respond to the deaths? How has it improved the quality of care? Professor Jamilu.
Yes. Thank you very much. I think I would say that the last 3 years, we've been doing more of demonstrating the evidence. So in terms of this data being used, it's just beginning now. I don't think we've done much of that. But especially for people to realize that one, preeclampsia and eclampsia is causing a lot of deaths, and that many women are dying from sepsis. So a lot of the facilities are now reviewing their protocols and training and retraining the health workers, especially the lower cadre health workers. Because one of the things about eclampsia is that a lot of the women are referred. So the mismanagement tends to occur even before they reach the hospital. So a lot of retraining is taking place in health facilities. And then one other thing I needed to mention is that we found out that this issue of companionship, when we analyzed the data, deaths were recorded more in women who had no companion. That is something that has not previously been studied in Nigeria. So we've presently looking into ways they can improve privacy and allow the presence of companions during labor, especially and childbirth. Now, there were questions about the neonate, and one of the things we found out also in terms of the neonate is that neonatal mortality tend to occur in women, in mothers who had complications. So if we improve the care to the mother, there will be less deaths in the baby. And that's why a lot of the emphasis is actually on the mother, because that's what the data showed. The deaths occurred in women who had complications. And the commonest cause was intrapartum emergencies. So once we improve on that, we believe that the deaths in the babies will also reduce. So I must say that we've done more of demonstrating the evidence, but in terms of action, it is just starting. But some few things have started, like I mentioned. Thank you.
Okay, thank you. And maybe related to that, how has this improved the overall data reporting for perinatal and maternal health for these hospitals that you are focusing on? And maybe back to Camille, is there a plan to integrate these into routine processes, or will the oversight committee that you elaborated be a permanent feature? You mentioned the nomination of a desk officer. Is there a plan to integrate this into the routine system? So we start with Jamilu, then to Camille, if the internet is better there.
Yeah, thank you very much. I hope you can hear me well now.
Yes, please.
Okay, thank you. Yes, in fact, one of the reasons why we have to make the formation of the MPDSR
Right.
committee.
Please, can you repeat mine? Hello, Martin.
Let's hear Camille, then I'll come back to you.
Okay.
One of the reasons is of setting up that facility level committee to even be shared by the chief executive is to improve stewardship at this level. We routinize the data collection and also strengthen the record system at these facilities, because I must tell you, it is not in a perfect shape yet. And once they know that data accountability is now expected on a regular basis with publication of results and publishing of trends across different tertiary health institutions in different states of the Federation. This will further strengthen use of data, collection of data, and decision-making using data at this level. And of course, it will also shape our policies at the federal level. I saw a few questions. Maternal death. So far, some of the data we've collected on MPD-4-QED has made us realize that hemorrhage is still a big deal, even in our tertiary health institutions. I'll make sure that oxytocin, judicious use of oxytocin is ensured. Also, availability of magnesium sulfate and prompt action for hypertensive eclampsia, having 24% case as Professor Tukur is also one way that we are supporting our community. All these data become routine and
Dr. Camille, your internet is really fluctuating. We can barely hear you now. So, Dr. Camille, your internet is really breaking up. So I'll just give a few seconds to Professor Jamilu, because our time is also coming to an end, to tell us how the implementation of this program has strengthened overall data reporting. Just a few seconds to respond to that, and then we hand over back to Tina to wrap up.
Okay, when we started this program, when we visited the Federal Ministry of Health, we were told that they were not getting a lot of good quality data from tertiary health facilities. This program has now given the Federal Ministry of Health and other stakeholders, including the WHO, a means to having an in-depth view of the state of maternal and perinatal health in patients that are attending tertiary health facilities. And like I said, what we have shared with you is just a tip of the iceberg of what is available on our platform. It's not only the QED indicators, any basic information from biodemographics to patient presentation, their clinical outcome for both mother and baby, because we collect routine data, is available. And also, this has strengthened research, because the fact that any research we want to do, this data is available for our people, for masters, for PhD, and so on and so forth. this is also something that has helped a lot. So there has been a big difference. The quality is very good. The only thing is that we need it to be maintained, because now we are really at the point of transition to the Federal Ministry of Health. We hope that all the processes, including the quality assurance that we have instituted over the last 3 years, will be maintained, and if anything, it will be expanded to other health facilities. Lastly, just to say that we are glad to say that this program covers all the states of Nigeria. There is at least one tertiary health facility in every state of Nigeria that is reporting its data to our database. So this gives us a very good picture of what is happening in the country. Thank you.
Thank you so much, Professor Jamilu. Back to you, Chair.
Okay, thank you, everyone. Thank you for the questions and the very interesting discussions as well. So just to wrap up, we would like to thank you for joining and let you know as well that the recording and materials for this webinar will be shared with you later this week via email. And you'll also will be available on the network website. So all the questions that were asked today in the chat, we have recorded, and we will respond afterwards as well. So we will share that with you later in the week. So thank you everyone for joining today. We'll see you all at the next webinar. Thank you and goodbye.